it is less than 90, you need to reduce insulin by 1 or 2 units, because people who are having fasting less than 90, they are having more risk of having nocturnal asymptomatic hypoglycemia. 3 a.m. glucose test and CGM can very well help you in understand the overall pattern, whether it is dawn or somogy or underbasalization. The somogy effect is very rare. Asymptomatic nocturnal hypoglycemic episodes, they are unlikely to produce a sufficiently strong counter-regulatory hormone response to raise blood glucose in the range that is being termed as hyperglycemia. Somogy effect, you should not think of somogy effect if the patient is having high fasting plasma glucose. You have to intensify insulin therapy, because mostly it is because of underbasalization. Thank you very much. Again, I thank the entire organizing team and Tamil Nadu State Chapter team for inviting me to be part of this important annual meeting. Thank you for kind attention.
Dr. Manoj Chawla for presenting monitoring patients on new incretin therapies.
Thank you, Chairs. Thank you, Dr. Shanmugavellu sir, Dr. Rajendran, Dr. Balamurugam and the entire Tamil Nadu RSSDI team for inviting me here and allowing me to speak on a newer topic. Very often we'll end up speaking for some of the drugs. So today my disclaimer is I'm not contracted for this talk, and these are my thoughts as we move ahead in important times of using the newer incretin therapies. There are certain aspects of monitoring that are becoming important. I'm not covering all the aspects that one should monitor, but certain important aspects that we are now learning may become clinically relevant. Well, GLP-1s, of course, the way they work, we're understanding that better. By decreasing appetite, food decreases gastric emptying, improves insulin secretion, and reduces the alpha cell overactivity. Tirzepatide, which is a dual analog, does more. It is essentially a molecule on the GIP background, so has high affinity for GIP and low affinity for GLP. So it does everything that GLP does, but on top of that, also because of its high affinity GIP action, increases insulin secretion, increases beta cell survival proliferation, and has an anti-inflammatory impact, which is why we see the benefits of this GIP-GLP molecule, which is getting popular day by day. Now, advantages of CGM over traditional blood glucose monitoring is today the real-time data. We no longer use those blinded professional CGMs much. It is all real-time CGMs. And of course, a lot of these CGMs today have alarms for highs and lows. So people who are using it, unless you put those alarms off, most of the systems now are going to offer you the alarms. And especially with the reduced gastric emptying and GLP-1 or the dual peptide usages, the chances of hypoglycemia are actually higher when you're using it with the other drugs. So let's understand what I'm saying. On one front, these drugs used alone claim to have a glucose dependent action. However, when you use them today, very often you're using them on top of other drugs. So the chances of hypoglycemia is increasing, and I'll show those in the cases. Benefits for patients and clinicians for CGM is going to be hypoglycemia management and enhanced treatment adjustments as you start using these drugs. Now this is a wonderful paper which is achieve individualized treatment goals in insulin treated people with type 2 diabetes. Now if you look at this, on the left side of this paper, they spoke about for patients who are on basal insulin, how do we go about improving their metabolic health, and they've strongly recommended the use of GLPs. Now if the A1C is more than 8 to 8.5, it says you initiate a GLP receptor with no reduction of the basal insulin. However, if the A1C is less than 8 today and you're starting any of the GLP-1s, especially the more effective ones, you need to reduce the insulin by 20%. Continue titrating slowly through the maximum tolerated dose of these drugs. When fasting readings are dropping less than 100, further reduce the insulin by 10%. And for those whose insulin or fasting sugars are dropping less than 70, decrease insulin by 20 to 25%. On the right hand side is wonderful points for additional best practices for clinicians today. consider placing a CGM as far as possible. Initiate at the lowest dose. There have been times that we've tried to initiate at a higher dose, or patient has told they'll tolerate, and sometimes that leads to problem. Ensure that patients are instructed to initiate insulin reduction on the same day when you're starting GLP. So a very important part today, that when you're starting GLPs and somebody is on insulin, the response can be much better than anticipated. So reduce the insulin. Dose adjustment of other medicines may be needed. Provide anticipatory guidance about antiemetics, your proton pump inhibitors, and so on. So let's look at some of the case scenarios that I've gotten for you today. The first one, a 58-year-old male, type 2 diabetes since 9 years, persistently high A1C over the previous 4 to 5 years, was not regular with his medications, had comorbid hypertension and dyslipidemia. 18th April 2024 last year, he sees me with the sugars of 142, 339 and A1C of 14.8%. The fact that this patient came in that day, it was because of the high sugars, and said that no, I want to change things. I have not been careful. His medications at that time was Idagas twice a day 20/20, vildagliptin, metformin, glyclazide, metformin, dapagliflozin. So the works, I think everything except a glitazone was there with 40 units of insulin. And yet the A1C was 14.8%. So you know something's amiss there somewhere. So patient, we recommended, okay, you're motivated, you're going to be more compliant with the medication, let's start monitoring. Let me put you onto a CGM. And we said, fine, let's get you onto a GLP-RA and insulin combination. So Iglar Lixi was available last year. We switched this patient from 40 units of Idagas to 30 units of Iglar Lixi. We continued the DAPA metformin and changed from the glyclazide metformin to glimepiride metformin voglibose. Again, the recommendations I showed you earlier says be wary of sulfonylureas also when you start these drugs. This was last year. I wasn't aware of these recommendations. I started the patient on this combination. The patient, of course, started getting more adherent and on the CGM could track things. Now this is in April 2024 itself. Look at the CGM tracks. There is variability that you can appreciate. You can also see is the hypo. TIR was 63%, but what the problem was 8% of TBR, out of which 4% was level 2 TBR, that means dropping below 54 mg/%. Now this patient was handling things because of the hypoglycemia. He was advised reduction of insulin. Dietary and lifestyle modifications were further promoted. The patient's TIR improved. So from 63 from April to June 2024, the TIR improved to 81%. You can also appreciate the band becoming narrower, so the variability decreased. But the TBR, as you can see, increased to 18%. So this patient, because he started getting more careful with the diet, started taking medicines regularly, the response was super. And he started reducing the medications, but the TBR increased, and which is where we have to be extremely cautious of monitoring these patients when you start these drugs, the GLPs and the GIP-GLPs. The patient's A1C decreased over a period of time from 14.8 to 7.9 over a 5-month period. Which gets me again to the other RSSDI consensus that we was part of SMBG. Again, in this consensus, we've strongly emphasized on the recommendations for SMBG. In India, SMBG still remains relevant. Everybody can't use CGM and can't use it continuously. So we talk about those who can use CGM also in between the CGM periods to still do a structured SMBG, which is helpful. And on the right side is one of the earliest consensus and recommendations of CGM that we did, was published in 2019. So that gets me to the case number 2. 44-year-old businessman, type 2 diabetes for 10 years. Again, has uncontrolled sugars, has weight gain, demanding work schedule, travel, all of that, has dyslipidemia. This is somebody that I would call as the yo-yo person, going up and down. 13.6% again HbA1c. This is 2022. Patient at that visit is advised to start insulin glargine, a glyclazide metformin voglibose combination, and a sitagliptin metformin in the afternoon. If the dapagliflozin was or EMPA was not given, it was because of the patient's symptoms or GU infection at that time. After starting this, patient reported occasionally feeling low while on insulin, had concerns about hypoglycemia, and hence we said, okay, let's stop the insulin. That happens at times. You look at a 13.6, you will start insulin, you want to give that. But some of the people with the change of OHAs, getting more involved in their care, within a few weeks they start getting hypo. So you want to knock off the insulin, fair enough. But we told, okay, let's start doing the CGM again to observe what is happening. This is the November to December 2022 snapshot. Already the patient was doing a 93% in target. So obviously telling us that except for those initial weeks, insulin was not required and monitoring was important. Patient estimated A1C was 6.1. Jan 23, the patient came to us, said, I want to lose weight, I have heard about GLP. So at that time we started on dulaglutide, 1.5 milligram. Glycoside metformin dose was reduced, sitagliptin was of course removed because we were starting a GLP dulaglutide. This is January 23. Patient's A1C improved to 7.8, weight was 101.2, this is again March 23. What happens after that? Well, so in March 23, when the patient improved and was doing CGMs, patient was brought down because of hypos to only metformin and dulaglutide. Well, they said, doing great, we should see the patient in May or June of 23 to see whether we are touching a 7% and what's happening to the patient's weight. But what happened was, patient disappeared for a year, which happens to many of our patients. And during that course, again with travel, with other aspects getting complacent, patient's A1C went up to 9.4. On his own, patient started glargine again and stepped up the oral tablets. In our country, you don't need a prescription. You can call up the chemist and say, send me glargine and send me these tablets, and they'll send you. So, and then he came to us in February 24 because his own efforts was not helping him. A1C was 9.4, he was gaining weight again. We said, okay, let's look at other treatment options. Let's start looking at the CGM again. At this point, we had tirzepatide last year available in the grey market, at least in Mumbai and other places. And this individual who travels and was well aware said, no, I have a source, I know I can get my tirzepatide, tell me to start. And he said, in the past I've had no issues when I have taken Iglar, Lixi and others. You give me, start with a higher dose, I don't want to start with 2.5. As I said, something that I would not do today, but this was last year. So started on 5 milligram. He was already taking glargine and sugars were still 9.4. So he said, okay, continue glargine. And patient was taking this glycoside, metformin, voglibose, so we continued. Again, a big mistake. As I said, I wasn't aware how these drugs work, and it would work to that extent. This is use of tirzepatide in 2024 February. So there is glargine, there is glycoside, metformin, voglibose, and tirzepatide 5 milligram. Look at what's happening on the day that he has taken this dose and then the days following that. The number of hypoglycemia the patient experiences starts on his own reducing insulin. Of course, these is connected care. So he messages our clinic, I can see the CGM on my laptop and advise the patient ki yes, start decreasing. Very soon we discontinue the insulin. And over a period of time, not only is the insulin gone, the sulfonylurea has gone, everything else is gone. Patient is only on tirzepatide, has lost weight 6.5. December 2024 is when I saw the patient last at my clinic, which was 12.5 milligram. Our patient had gone up to 12.5 milligram. Look at the GMI or estimated A1C, 5.3. Look at the sugars. This patient is only on tirzepatide without any other medication. What are you noticing? The lows. And that's another new learning for all of us. When you have your patients on these drugs without any hypoglycemia causing drug, and you do a CGM, you will see a lot of sugars in the 60-65 range. Patient is absolutely comfortable. This is not hypoglycemia. It's hypoglycemia if there are symptoms and if the patient is on hypoglycemia causing drugs. So if you start reacting to it, patient will reduce the drug and not get the advantage of weight loss. So when you're using in a lot of patients who achieved remission or are non-diabetic and you do a CGM, you will see 60s. One, start looking at time in tight range and don't worry about the lows as long as they have no symptoms of the same. So that's important learning. These were our papers again on time below range, which is so important in today's times. Quickly in the last 2.5 minutes, two more case scenarios. This is an individual History of pre-diabetes, CT angiography reveals certain blockages. A1C is 5.7, so at the cusp of pre-diabetes, essentially patient wants to lose weight. We start this patient on tirzepatide.